The next theme is insights from Singapore into the clinical features and transmission of SARS CoV2, the cause of COVID-19. Senior consultant Paul Anantharajah will deliver the presentation. And Professor Tambyah earned MD in Singapore, and currently he is working as a professor at Department of Medicine of National University of Hospital, Hong Kong. And he is working as a member of many institutions. And also, other than that, there are many commissions where he is a member of. So I believe he will be deliver a very informative and productive presentation. Let's meet him.
Okay, good afternoon. My name is Dr. Paul Tambyah. I'm an infectious disease physician from Singapore, and I'd like to share with you some of the insights that we have had from the COVID-19 outbreak in Singapore. Many of us underestimated the virus. I have a concurrent appointment at our National Center for Infectious Diseases, and we awarded small grants. So at the beginning of the year, we awarded a grant to one of our scientists to go and visit the Wuhan Institute of Virology in Wuhan. She wrote to us and said that there had been a virus outbreak and she had to cancel her trip. She couldn't get a reimbursement from the airline. And I wrote back to her and I said, we should try and reimburse her only if she can provide documentation that she was told not to go. If she was scared of getting pneumonia, then we should not reimburse her, which in retrospect was a pretty silly thing to say. Because as you now know, there have been more than 21 million cases of COVID-19 all across the world. Now, I'm a clinician, and this is an example of a patient that we took care of, a rather unusual one. She's a 72-year-old woman with only mild diabetes. She felt unwell with some dizziness, went out with friends in the morning, became drowsy on returning home, collapsed in the ambulance, was resuscitated. Now, this is a brain scan. And what you can see is this is the normal brain, and this is blood. So she had an extensive amount of bleeding in her brain. She was terminally extubated because they decided that there was going to be no good neurological recovery. But an alert emergency department doctor noticed that she had a chest x-ray, which was really abnormal. And so she did a test for COVID, which was positive. And we did an antibody test post-mortem, and that was also positive. This lady was reported in the media, and she was confirmed to have COVID-19 infection, but the cause of death was listed as bleeding in the brain or intracerebral hemorrhage. So this is one of the features of COVID-19 disease, which is different from a lot of other pneumonias, in that there seems to be involvement of other parts of the body beyond the lungs, in particular the brain and the heart. And there's a theory that this is related to activation of the immune system affecting the lining of the blood vessels. So how has COVID-19 appeared in Singapore? The first cases appeared in January, and they were from travelers coming in from Wuhan, like in other parts of the world. Subsequently, we had large community outbreaks in April, and then we had a full lockdown. And then we had outbreaks in the migrant worker dormitories, which continue to this day. We've tested 600,000 individuals, of which more than 50,000 have turned out positive. The mortality in Singapore appears to be low, but it is primarily age dependent. And in Singapore, amongst individuals over the age of 80, the mortality is 20%, which is about the same as in Italy, China, Korea, Spain as well. Now, the first patient I presented was a very unusual case of COVID-19 disease. This is a far more common situation. 38-year-old healthy person saw a general practitioner when she developed a fever and some mild symptoms. She was given some antibiotics, rested at home, and then she developed shortness of breath. She went back to the same general practitioner who referred her to the emergency department. She was on leave, and then she got better. She wanted to come back to work in the hospital, so she went to employee health, had a swab test done, which was positive. By this time, she was completely well, no symptoms at all. But because she was swab positive, she had to be kept in hospital for another 10 days. And that was unfortunate. The other extreme and more typical case of severe disease, 53-year-old man, coughed for a week, fever. He was intubated, put on mechanical ventilation, was treated with antiviral drugs, with interferon, with antibiotics. He collapsed, had to be put on a heart-lung machine, developed multiple complications, including liver disease, blood clots, and a bleed in his intestine. His SARS CoV PCR was positive on multiple occasions. He was finally extubated. He's been discharged. He's walking with a stick, and he came to the clinic asking for medical clearance to get him a taxi license, which I didn't really think was a good idea. So you have a spectrum. You've got severe disease, which can be fatal. You've got severe disease, which is not necessarily fatal, but the vast majority are mild or asymptomatic. And this makes control of the disease very difficult. With SARS in Singapore in 2003, a few individuals, A, B, C, D, and E, were the so-called super spreaders who spread the virus to the majority of individuals. Similarly, with the COVID disease, the vast majority of people do not spread the virus to anyone at all, or at the most 1 or 2 people. But you have a handful of super spreaders who can spread the virus to tens or dozens of people. And this makes, again, the control of the virus very difficult. In Taiwan, they did very careful analysis of the spread of the virus, and they found that the biggest spread was in households, healthcare, and other settings. Even though they had multiple contacts, they had zero spread to those settings. So these super spreading events have been modeled by my colleagues from Hong Kong and Japan. And what we showed was that SARS-CoV transmission within households seems to be at higher risk, but this is because of when people are staying at home. Obviously, they're going to start spreading it at home rather than in workplaces, but areas such as the dense migrant dormitories are where these super spreading events can occur. So it's important to understand the epidemiology of spread of the virus. And this has been done in various papers, including this one published in The Lancet early in the outbreak. And what you can see is that there were multiple clusters of the virus spread, and a lot of them came from individuals. And I believe the same has been true in Korea as well. Unfortunately, these clusters have continued, and this is what was going on in May and June, where we had multiple clusters in migrant worker dormitories, as well as in certain social and cultural events. The dormitories in Singapore have been major areas of spread of the virus because these are very crowded. You've got between 15 and 20 individuals, sometimes crowded into one room, with all of them sharing one toilet facility. The conditions in these dormitories are very challenging. We have doctors who go and screen patients in these dormitories without chest x-rays or point of care testing, and all they do is they're able to do swab testing for these individuals. And this has resulted in extraordinarily high rates. And this has been termed the Singapore syndrome, where we have, in this case, in a publication here, where there were 1,800 out of 6,000 foreign workers who are symptomatic. And of these, 69% of them were found to be positive when tested for COVID-19, which is probably one of the world's highest test rates. There are many reasons why this has occurred. One of them was an unfortunate decision early on to reduce the testing rates amongst migrant workers who are asymptomatic. And that was because there was a concern that the hospitals were being overwhelmed by large numbers of asymptomatic individuals going to be tested. The result of this was that many infections were undocumented, and asymptomatic or pre-symptomatic individuals spread the virus rapidly in these migrant worker dormitories. So what the authorities in Singapore did was they sealed off the dormitories, they locked them down, and unfortunately this resulted in what's known as the Diamond Princess syndrome, similar to the cruise ships. And what that does is, in Japan, when they sealed off the cruise ships, that protected the people in the city, but it resulted in spread of the virus on the cruise ship itself. And that is essentially what has happened in the migrant worker dormitories. Although most of the migrant workers are young and healthy, we had a small number of them who became critically ill, including one in the earliest part of the outbreak who was in the intensive care unit for more than a month. He was fortunate, he survived. And in fact, interestingly enough, back home, his wife gave birth to a child. So why is this virus so difficult to spread? And one of the reasons is this so-called asymptomatic carrier transmission, which was documented late in January and February from China as well as in Germany. And unlike SARS, the virus tends to have a very high viral load early in the course of the illness, which tends to drop off over days 9 and 10 of symptoms in the nose and in the throat. overall. This is what we've seen in Singapore with our patients, and it's in marked contrast with what was seen with SARS in Hong Kong and in Singapore, where you see patients' viral load peaking around day 10 of the illness when the patients are most ill. So that is the reason why SARS and MERS tends to spread in hospitals, whereas COVID tends to spread outside of hospitals in preclinical settings. So this concept of pre-symptomatic transmission, in other words, you can spread the virus before you have fever or before you have any symptoms, was well documented in Singapore. In this paper published in the Mortality and Morbidity Weekly Report in April from Singapore, where there were 7 cases of well-documented pre-symptomatic transmission occurring in Singapore. One of the most interesting occurred in a church in Singapore. And what happened was this was an independent church that had some visitors from China. So 2 individuals, C1 and C2, they were not church members. They attended the morning service, left immediately after the service, did not have contact with anyone in the church, and based on closed-circuit TV findings, so this is not interviewing people, but reviewing closed-circuit TV, and don't ask me why they had closed-circuit TV. Maybe they were afraid people would take from the offering bag. They found that an individual occupied the same seat as these people, didn't meet them, and then got infected. So they screened 191 church members, 142 of them attended the service, 6 of them were unwell, and none of them tested positive. Now, people have argued that this virus may be airborne, but if it's airborne, it's incredible that it didn't infect 191 or 142 individuals who shared the same air supply as these 2 super spreaders. So I'm very skeptical about that. But this idea of airborne spread of the virus is a very common one. It reigned in medicine for 1,500 years, from the time of Hippocrates to the time of Louis Pasteur. And it was fueled by this paper in the New England Journal of Medicine, where they looked at aerosols and the virus remaining viable in aerosols for more than an hour. But I always tell my students, read the fine print, and you'll realize that they use high concentrations of virus in a high-powered jet nebulizer in a drum, which was used for biological weapons testing. So naturally, this is a very artificial environment. The same group from Nebraska also used a sampler at the foot of a patient's bed and managed to find some airborne live virus. In contrast, in real life, in Singapore, the National Center for Infectious Disease were unable to find air samples in patient rooms in negative pressure air handling environments. Similarly, the original group in Nebraska also were unable to find culturable virus, although they have subsequently been able to do that using a different method. Conditions do matter. At 37 degrees centigrade, the virus disappears after 1 day. At 22 degrees centigrade after 7 days, and at 4 degrees, the virus can hang around for more than 14 days. So this has been a huge controversy. 239 scientists criticized the WHO about this airborne transmission issue. They asked me to sign this paper, but I refused because I do not believe in this aerosol transmission. Some of them in the same group were unable to show this for influenza, but somehow this idea of airborne transmission for which you need an N95 mask is widely believed. During SARS, N95 masks were widely available. We even had a bank robber using an N95 mask to rob a bank, but he found it so uncomfortable, he put it on his head and he got caught by the security camera. So what are the interventions that have been used to mitigate the spread? There's use of quarantine, use of school closures, and use of workplace distancing. And these have been shown to try and control the spread. But the question of how long they are sustainable is another issue. On the 3rd of April, they introduced this so-called circuit breaker, which is a very severe lockdown with strict penalties where individuals could not move in and out of their houses unless they were doing urgent grocery, food, or healthcare needs. And these laws are taken seriously. One individual was charged in court for going to work to deliver newspapers on 1 day, and he eventually ended up going to jail. So nature benefits from these lockdowns. We had wildflowers growing where they had died out. And interestingly enough, influenza rates also dropped thanks to the lockdown because people were not socializing, and influenza transmission was at its lowest for a very long time in Singapore. But other diseases continued. Migrant workers are also at risk of tuberculosis, and we reported a number of them with both tuberculosis and COVID-19 disease. So this question about social distancing also comes up. And this is based on this whole thing about lockdowns is based on this paper published in The Lancet online on June the 1st. And what you can see is there were a number of papers that they reviewed, although in coming up with this paper by Burke was reviewed 3 times in contributing to the meta-analysis. The first paper by Pai et al. Was actually a study of sleep deprivation, and they only remotely looked at contact with the index case. So I don't think this is very convincing. In Tu Hai, they also were not able to convincingly demonstrate the impact of social distancing. And this is the most important paper in that group because it was cited 3 times. It was done by the US CDC, and essentially they looked at a number of household contacts and healthcare contacts. And what they found was that there was actually no transmission to any of the healthcare contacts or household contacts, except for the spouses. There were only 2 transmissions, 2 additional cases, and these were both spouses of travel-associated case patients. The other 402 patients' contacts were not infected. Children also seem to have a relatively low risk of infection, and it's not entirely clear why. Some people think that they shed virus, but they may not be able to get infected themselves for a variety of reasons. One of the more intriguing things is the idea that children may be protected by recurrent exposure to other coronaviruses. And we and others have shown this. A group led by Dr. Antonio Bertoletti from Singapore showed that individuals who had recovered from SARS 17 years later still have T-cell responses which protect them from SARS. And this is very encouraging for those involved in vaccine development, because you may have heard about the so-called waning of antibody levels. But irrespective of antibody levels, if you have T cells which protect you against SARS once you've been and SARS CoV2 once you've been exposed, then there's a good chance that you'll be protected for a long time. Ultimately, though, this is a global problem. We lived in a globalized world. We don't know whether we'll go back to a globalized world, but this virus has shown us that no one is truly safe until everyone is truly safe. I thank you.
Thank you very much, Professor Tambyah. He talked about clinical things about the COVID-19 and the transmission and widespread of the virus as well.